Today's lecture is about ectopic pregnancy. Can you hear me okay when I'm speaking? Yes, okay,
Yes,
cool.
yes, clearly.
Okay, perfect. So today's lecture is about ectopic pregnancy. It won't be very long, maximum 20, 30 minutes. But as we go through ectopic pregnancy, I thought it would be helpful to know first what a normal pregnancy is and what we mean by an ectopic pregnancy. So if you all remember your physiology, for a pregnancy to happen, you need to have an egg that is released from the ovary. The egg is released from, sorry, there's a bit of noise. The egg is released from the ovary here. It goes into what's it called again? The name just completely off my head. The fallopian tube, and then as it's traveling in the fallopian tube, a sperm will come and fertilize the egg to produce an embryo. The embryo will keep traveling until it implants itself in the lining of the uterus. What happens with a ectopic pregnancy is that the implantation goes wrong. So you still get the release of the egg, you still get the fertilization of the egg, you still get an embryo that forms, but instead of it implanting here in the middle of the uterus, where you have the cavity and the space for it to grow, it implants somewhere else. And the main common places for it to implant itself is the fallopian tube. That's the most common, but it can also happen in the uterine cornea, the cervix. Sometimes extremely, extremely rarely, it can just happen in the ovary itself, or just completely outside of the reproductive organs in the general pelvis, which we'll talk about a bit later as well. So this is just an image that explains the common places for an ectopic pregnancy to happen. The most common place for it to happen is in the ampulla of the fallopian tube, so this area here. After that is in the isthmus of the fallopian tube, so this area here. So fallopian tube is easily 92%. The fimbriae is 5%, and then you can get it sometimes to happen in the cornea, in the abdomen completely outside of the uterus, in the ovaries extremely rarely, and in the cervix very, very rarely, 0.2%. But for the purposes of this lecture and just in life in general, most commonly it's either in the fallopian tube or what we would call a pregnancy of unknown origin, of unknown location, because it's hard to find it otherwise. Sorry, I can't change the thing for some reason. Cool. So, like I said, most ectopic pregnancies happen in the fallopian tube. Risk factors. So, any risk factors that will increase your risks of getting an egg implanting somewhere it shouldn't is if you have any scar tissues. So, if you have lots and lots of scar tissues around the fallopian tube or around the uterus, that will prevent the egg from traveling safely to where it should implant itself, to the endometrium. If things that can cause scarring in the pelvic area is things like an STI, so if you have a sexually transmitted infection that then develops into PID, so pelvic inflammatory disorder, where you have an infection just around the pelvis, that generally causes scarring to happen in the area. If you had a previous ectopic pregnancy, that increases your risk of getting another ectopic pregnancy. If you had previous pelvic surgery, so any surgeries that you have in the abdomen, in the pelvis, will increase your risk of getting scarring in that area. Tubal abnormalities or damage is just, again, either from a big infection or from a surgery. Pelvic inflammatory disease, like I told you. Infertility, and again, infertility, that pretty much goes with just the scarring in general. That's why they're infertile, because the tubes are blocked. And people who smoke in general are just at a bit of higher risk, because you have more inflammation going on, you have more scar tissue going on in general throughout the body. Your vessels are less healthy as well. You also have something called heterotopic pregnancy, which is not very common at all. In the normal population, it's about 1 in 30,000. But a heterotopic pregnancy is when you have both an ectopic pregnancy and an intrauterine pregnancy. So what we mean by an intrauterine pregnancy is a pregnancy that has implanted where it should implant, so in the endometrium. So this pregnancy here, that's an intrauterine pregnancy. That's what we want all pregnancies to be. That's what is a healthy pregnancy, and that's what will deliver to term. So in a heterotopic, you have both intrauterine and ectopic pregnancy. Very rare in people who have gotten pregnant spontaneously, but a lot more common in women who have used things like IVF and other assisted procedures to have become pregnant. In the group of women that are using those technologies, it's about 1 to 2%, so a lot more common than you would expect. So why do we worry about ectopic pregnancies? So if you look back at this image here, if you have a pregnancy that implants itself in the fallopian tube, it just doesn't have enough space to grow. So as it's growing, it's not going to have enough space, it's not going to have enough vessels, it's not going to have enough blood, it's not going to be able to grow properly until it gets to the point where it will rupture. That's why we worry about ectopic pregnancies, because they can be medical emergencies. So they can cause death. If you have an undetected ectopic pregnancy and it comes to week 12, week 13, and they have pain and it suddenly ruptures, it can be very, very hard to save patients at that point, because they bleed very heavily, they can get sepsis, they can get infections. It does happen, but that's why you want to find them beforehand, before they reach the point where they're rupturing their pregnancy. The symptoms before the rupture can vary pretty much. Sometimes they will get a bit of pain. It tends to be different from normal pregnancy pain in the sense that it tends to be more one-sided. So whichever side that the fallopian tube it's implanted on, that's where the pain tends to be. It tends to be a lot more severe than sort of normal cramping pain that you expect with pregnancy. And it tends to be from sort of week 4, week 8 to week 10. That's when you expect patients to come in with symptoms of an ectopic pregnancy. And once it's ruptured, then you can have very sudden severe pain. So you get a lot of guarding when you're examining them. They can lose consciousness because they're losing a lot of blood. There's a lot of hemorrhagic shock, peritonitis, because of all the blood that's going into the abdomen, into the pelvis, that can lead to infection. When you examine patients that have an ectopic pregnancy, things you're looking for is for tenderness, and that's unilateral tenderness, not just generalized tenderness, but more that's on one side. Cervical motion tenderness, I tend not to do that when they're pregnant, because we know that it can increase the risk of a rupture if you're doing it, but it's one of the signs. And usually it's unilateral adnexal. So when we say adnexal, we mean right iliac fossa or left iliac fossa tenderness. And sometimes you can feel a mass there. You can feel something very small that's soft and round. You should be careful so as not to put excessive pressure, because you don't want to rupture that pregnancy and cause a problem. So as a general rule of thumb, all pelvic pain in a pregnant woman is an ectopic pregnancy until proven otherwise. So anyone who is pregnant and goes to an accident and emergency department here, and they tell you they have pain, until you have proven for sure that this pregnancy is intrauterine and it's in the right place, you don't really examine, you can't think of anything else. You can't think of appendicitis, you can't think of all of that until you have made sure that this pregnancy is definitely intrauterine. But any woman who's coming in the age of where they're fertile, so from the age of 15 to probably 40, and they tell you they have low abdominal pain, that's one-sided, comes and goes, the first thing you want to do is a urine pregnancy test. If it's negative, good, you're reassured. If it's positive, you do want to start thinking about, could this be a pregnancy that's not implanted properly? Once you know that they are pregnant and they have the pain, what you do is you refer them to the gynecologists and they take it from there. But what they usually do would be either do a scan, but a scan, if you're very, very early on in the pregnancy, they're not able to visualize the egg and the yolk of the implantation. So they wouldn't be able to tell you for sure if it's an intrauterine pregnancy or if it's an ectopic pregnancy, simply because they can't see it. It's too small. So then what they do when they can't see it is they do beta-HCG testing in the blood. So in a normal pregnancy, you expect beta-HCG to go up by 2 to double every 48 hours. Whereas in ectopic pregnancies, the levels don't increase as much. They increase a lot slower. So if you can't visualize it on the scan, you take their bloods today for the beta-HCG, you take it again in another 48 hours and you compare. If we usually say that the beta-HCG should be at least 3,500 before you can actually visualize it, before it's big enough that you can visualize it in an ultrasound scan. But even if you've scanned several times and you can't visualize it at all, so you don't know where the pregnancy is, then you would just diagnose that as a pregnancy of unknown location, which is an ectopic pregnancy, but you can't confirm where it is. So you can't confirm if it's in the fallopian tube, in the cervix, in the uterine. You can't confirm where it is. So you're treating it as an ectopic pregnancy, and you want to treat it before it ruptures. So that's, like I said earlier, a ruptured ectopic is a medical emergency. Consider that in any woman that has severe abdominal pain, losing consciousness, is in shock. When you examine, you will get a lot of guarding. They'll be hypertensive, tachycardic, etc. So if you've managed they had a bit of pain before it's ruptured and they've come to you and you've done your beta-HCG, it's now over 3,500, but you're scanning and you still can't be sure where it is. So you diagnose it as a pregnancy of unknown location. Then what you can do is you can give them methotrexate. So it will shrink it and kill it. Or you can do a surgery, but you can't do a surgery for pregnancy of unknown location because you don't know where it is. So you don't know what you're looking for, where you're going to go to remove this. If you know where it is, if you've visualized it on your ultrasound scan as being in the fallopian tube, then you can do a surgery. You can remove the fetus, the placenta, and part of the fallopian tube that you can't repair. But the general idea is you want to repair as much as possible and keep as much as possible intact for future pregnancies. If you do end up giving them methotrexate, there are times where methotrexate doesn't work. So you have to keep doing beta-HCG testing to make sure that the hormones are going down, to make sure that the pregnancy has shrunk and has self-aborted. Otherwise, you have to do another course of methotrexate. And the treatment for ruptured ectopic is always surgery. Sometimes, depending where the bleeding is, sometimes you do end up having to do a hysterectomy or just a removal of wherever it is that is bleeding. But that's the general gist of it. I think that's it. I told you it would be nice and sweet today, nice and short. Any questions at all?